Okay, sir. Okay.
Yes.
So we all know that irrational prescribing is actually a global health problem right now. So knowingly or unknowingly, we are all part of this irrational prescribing or irrational drug use. So I'll be talking about irrational drug practices in general, not only regarding antibiotics, and how do we promote the rational drug use. So what is actually the rational drug use? It is actually use of medication appropriate to the clinical condition in dose that meet the individual requirement for adequate period of time at the lowest cost to them and their community. So basically, it is individualizing any prescription. We are treating as a patient, as an individual, not as diagnosis, right? So basically, the thing is that we need to maintain the same criteria. That is, the safety has to be assessed, affordability of the particular drug what we are prescribing, and what is the need of the therapy, and the efficacy of the treatment. So basically, the rational drug use includes 5 rights. That is the 5 drugs, 5 dose, right dose, and then the right route of administration for the right time or right duration, and for the right patient. So the aim of this rational drug use is actually to maximize the effectiveness, to minimize the risks of any therapy, and then minimize the cost and respect the patient's choice. Okay. So as we all know, prescribing is a complex process, and the main aim of any prescribing is to cure illness or relieve symptoms and to prevent future diseases. So any rational prescribing, it includes the diagnosis of a particular disease. It includes the differential diagnosis, and we need to assess the prognosis of the condition as well. And then we reach into a goal of the therapy. The goal of the therapy can be the prevention of future diseases, to prevent long-term complications, or to treat the patient, to actually completely cure the illness. And for that, we will have multiple treatment options. It can be pharmacotherapy, or it can be a simple physiotherapy, or it can be a surgery. So these treatment options, we assess based on the risk-benefit ratio, and then the availability of the treatment, cost of the treatment, then what are the patient expectations, and the physiological status of the patient. Say, for example, hepatic or the renal status of the patient. Based on the age of the patient, sex of the patient, we assess the treatment option and then prescribe. And the most important portion of, is the patient counseling. So I'm just talking in terms of correct or ideal situation, not in the current situation where we have got excessive patient load. Okay. And then patient counseling is the most important step. And also we need to assess the susceptibility to adverse effects. So in any prescription, it is very important to document the history of previous adverse effects and what all medications the patient is currently on. And then monitoring the patient is also very, very important, because we know that every treatment we are giving, it is actually different for each patient. So each patient may not have a very good outcome. Some patient may end up in drug interactions or may end up in any adverse drug reaction. So it is very relevant to monitor the particular patient. So the key is the patient communication. In the current scenario, it is difficult. We'll talk about that. So what are the stages of inappropriate use of medicines? Till now, I was talking about the ideal situation. So inappropriate use of medicine can happen at any of these stages. It can happen at the level of diagnosis. Maybe we can make a wrong diagnosis, or in follow-up also it can be difficult. There can be any wrong diagnosis that can be made. And at the level of prescribing, maybe because of the illegitimate prescription or what we have written, it's not clear. There can be dispensing errors, and also there can be problems with the patient adherence. So the major factors concerned with influencing factors which are concerned with the rational prescribing, or which can account for irrational prescribing. Maybe whatever we are prescribing can be rational or irrational. The influencing factors are the following. Obviously, it is the knowledge of the treating doctor, and we all may have a role model. There can be a senior, there can be a teacher or a colleague. based on them, we can have a role model. So obviously, our treatment can be influenced, or our prescription can be influenced by the role models also. And then patient load. If we look in our OP settings, if we 100 to 150 or around 200 patients in a 1 minute or 2 minutes spare. So automatically we are acting as a machine. So obviously there can be error which can account for irrational prescribing. And then obviously empirical treatment. Empirical treatment is very common nowadays, especially in an FHC setting or in this health service setting where patient can't afford. Patient may not be able to afford lab investigations or drug sensitivity testing. So in that condition, we are forced to write an empirical prescription which can result in irrational prescribing. Now, the patient demand is also a very common influencing factor. We all know patients patients demand in a condition. They are demanding for antibiotics. And then self-medication is also common, which can result in inappropriate use of antimicrobials. Patient one time a day stop. Situation so patient demand and self-medication is being increased in these days. And then availability of the medicines. Now we are actually facing the situation. Most of these are health institutions. We are having a poor availability of medicines. Medicines are whatever available medicines are there, that's prescribe. So it can be irrational as well. And then infrastructure, poor lab facilities. So lab facilities are there, but maybe due to the financial burden of the patient or financial status of the patient, we are forced to prescribe the drug which is empirically. And then claims by pharmaceutical companies. So whatever information we are getting is based on usually practitioners drug it is dependent on pharmaceutical companies and medical representatives. These informations can be often biased. They will be usually exaggerated claims will be made. So we tend to rely on those pharmaceutical company representatives as well. So this also can account to irrational prescribing. So this study actually shows the importance of patient pressure and perceived pressure, perceived medical need in doctors' prescribing practices. According to this study, it was stated that doctors themselves know that what we are writing is irrational, and it is based on the patient demand and patient pressure. So here comes the relevance of patient education. So patient education is very, very important in case of rational drug use. So now we'll move on to what are the different types of irrational prescribing. So irrational prescribing basically includes the following, that is under prescribing, over prescribing, incorrect prescribing, extravagant prescribing, and multiple prescribing. We'll come to each. So under prescribing mainly includes inadequate dose or duration. In this condition, that means a therapeutic indication is left untreated. It is because of inadequate dose or duration, and it's most common in case of inappropriate use of antibiotics. Usually, I told you earlier, it is because of the self-medication. Self-medication of the self-medication by the patient without any prescription. Correct duration or maybe they are taking not in the correct dose. There may be underdose. This can result in increased morbidity as well as mortality. And this underprescribing is especially common in case of pediatric population as well as elderly population. Maybe your fear of adverse effects, we tend to reduce the dose for elderly and pediatrics. Sometimes that dose might not be enough for that particular patient, which can result in serious morbidity. And then inappropriate use of antibiotics that I already mentioned. Now we move on to overprescribing. Overprescribing is usually seen in our setup. We tend to use medicines unnecessarily, especially if patients has got a psychological impact. They have got that every ill has got a pill nullary readilana our concept. For every medication, every disease, the doctor should prescribe some medicine. So we are also under that pressure, and we tend to prescribe medicines even without making a proper diagnosis. Upon unnecessary use of vitamins and tonics for sadharana or muscle pain, or without even diagnosing the problem, we tend to prescribe multivitamins or calcium supplements. And then unnecessary use of antibiotics in viral fever is very common. Similarly, unnecessary use of antimicrobials in diarrhea, and long duration of antibiotics, especially in case of post-operative patients. Post-operative patients, like even without drug sensitivity, culture and sensitivity, we tend to increase the duration of the treatment of antibiotics. Incorrect prescribing is basically medicine is given for a wrong diagnosis and not considering previous history of allergy. It results in iatrogenic diseases, which in turn can result in adverse drug effect because of the particular drug itself. That is why the documentation of the previous history of adverse effects is very, very important. And then not considering physiological conditions, especially in elderly people, we tend to prescribe. They often ask for NSAIDs, often ask for painkillers. Actually, we need to understand that elderly, as they are having poor renal reserve as well as hepatic reserve, so they can end up in adverse effects. Then not considering current medications, it can result in drug interactions and adverse effects. Then excessive use of injections where oral formulations can be prescribed. It results in increased workload to the nurses and the medical staff, and also it can result in unnecessary local reactions as well as abscesses. And then excessive use of fixed dose combinations, will come to that. So I'd like to just discuss some of the common irrational prescriptions which are seen in our OP setup. So the first one is ciprofloxacin with derifilin. Because of the availability, surplus availability of both of these drugs in our health setup, we tend to prescribe them together. Often we tend to prescribe. So ciprofloxacin is actually an enzyme inhibitor. So this ciprofloxacin inhibits the metabolism of derifilin. So it in turn increases the blood concentration of derifilin, which in turn can result in the gastric, CNS, even cardiac adverse effects in those patients when we are giving ciprofloxacin with derifilin. But these combinations usually prescribed in case of LRTA or asthma, elderly asthmatics in case of any infection. So ciprofloxacin is better be avoided in these patients. And then
slide change ആവുന്നില്ല
yeah,
ഇല്ല ഫസ്റ്റ് സ്ലൈഡിൽ തന്നെയാ നിൽക്കുന്നത്.
അയ്യോ,
ഇപ്പൊ ചേഞ്ച് ആയണ്ട?
ഇപ്പൊ ചേഞ്ച് ആയോ?
ചേഞ്ച് ആയി.
ഇപ്പൊ സിപ്രോഫ്ലോക്സസിൻ വിത്ത് ഡെറിഫിലിൻ എത്തിയോ?
അത് യെസ്, കാണാം.
ഇപ്പൊ കാണുന്നുണ്ടോ? അങ്ങനെ ഉണ്ടെങ്കിൽ ഒന്ന് പറഞ്ഞാൽ മതിയേ. ഒരു മിനിറ്റ്.
കാണാം.
ഇപ്പൊ കാണാനുണ്ട് അല്ലെ? ഇപ്പൊ സ്ലൈഡ് ഷോ ആയിട്ട് കാണാനുണ്ടോ?
ഇല്ല, മറ്റേ സ്ക്രീൻ ഫുൾ ആയിട്ട് കാണാം, പക്ഷെ ഈ ഇത് റീഡ് ചെയ്യാൻ പറ്റുന്നുണ്ട്.
ശരി. താങ്ക് യു. It is better to avoid prescribing ciprofloxacin in those patients who are on derifilin. And then next commonly seen prescription is clopidogrel with omeprazole. Obviously, we all know that coronary artery disease patients, mostly they are on aspirin and clopidogrel. So they will have gastrointestinal adverse effects, and for that we often prescribe proton pump inhibitors. It is better to prescribe pantoprazole over omeprazole. So many studies shows that those patients who are on clopidogrel, when prescribed with omeprazole, there was increased incidence of exacerbation of their symptoms, and it was found that it is because of interaction between clopidogrel and omeprazole. So basically, clopidogrel is a prodrug. So prodrug, for its action, needs to be activated by an enzyme, and that particular enzyme is actually inhibited by omeprazole. So in those patients who are on clopidogrel, when prescribed with omeprazole, it causes decrease in the efficacy of clopidogrel and can result in increased risk for thrombosis. Now, the next commonly seen prescription is fluconazole. When we, in case of candidiasis in patients who are on atorvastatin, especially these cardiac patients, when they are prescribed also, there is increased risk of myopathy. We all know the adverse effect of atorvastatin, that is the myopathy is a common adverse effect. Usually it is perceived as severe muscle aches, which is routinely complained by the patient. So when we give fluconazole additionally in case of candidiasis, what happens is fluconazole is basically an enzyme inhibitor. It inhibits the metabolism of atorvastatin. And so what happens is there is increased blood levels of atorvastatin, which can increase the risk of myopathy. So better we need to give any other drug, any other antifungal like terbinafine can be given for candidiasis, or we can go for any topical preparations if we want. Same is the case when we combine fluconazole with glimepiride in case of diabetic patients. It can result in hypoglycemia by increasing in the blood levels of glimepiride. And then NSAIDs. Next is common prescription is NSAIDs. That is the non-steroidal anti-inflammatory drugs, which includes commonly prescribed diclofenac, aceclofenac, meftal. Usually elderly patients are very common. Elderly patients, they demand for painkillers for their muscle pains, joint pains and all. So we tend to prescribe them. But as I have already mentioned, elderly patients, they are having poor renal and hepatic reserve, and they are more prone for adverse effects, especially if they are on antihypertensives like ACE inhibitors, which include enalapril, ramipril, losartan, telmisartan. They are the ARB or angiotensin receptor blockers. What happens is NSAIDs can actually, they are acting by reducing the prostaglandin synthesis. They are anti-inflammatory drugs. They reduces the prostaglandin synthesis in the kidney, and it can reduce the blood perfusion, renal perfusion, which in turn can increase the renin secretion, which can increase the blood pressure. So there can be sudden increase in blood pressure if we prescribe NSAIDs in case of antihypertensive. So this is an irrational combination, and ideally it should be avoided. Same as in the case of prescribing NSAIDs, we should be careful in case of coronary artery disease patients, as there is increased risk of gastric bleeding, and it can interfere with cardiac protection. So the next commonly prescribed combination is Ampiclox, then Ciplox TZ. These are routinely prescribed in the So they are actually fixed dose combinations. So fixed dose combinations or fixed drug combinations means two drugs are actually combined together in a single formulation. So individually, these drugs are actually approved by FDA and CDSCO. That is, our Indian regulatory drug in the regulatory body. They have approved individually these drugs, but as a new formulation, when they are combined together in a new formulation, that is actually acting as a new drug. It also requires a regulatory approval as a new drug. And both these combinations and many other FDCs are there. I've just included commonly seen prescriptions in our OP setup. Ampiclox is now actually second most common FDC being prescribed after Moxclav in terms of antibiotics. Ampiclox, one thing is that it is not FDA approved, and the next thing is that it is being given in half the dosages. Adult dose of ampicillin and cloxacillin is 500 individually. So when both of these antibiotics are given in half the dosage, there is increased risk for antimicrobials. And also cloxacillin, it is basically active against staphylococcus and other gram-positive cocci. And Ampiclox, even though it is said as broad spectrum, it is a broad spectrum, it is mainly active against gram-negative bacteria, gram-negative bacilli. And both these conditions actually rarely coexist. So in any condition, when we are prescribing either of these drugs attain or these or bacteria attain resistance against either of these antibiotics. So we are accounting for antimicrobial resistance when we are prescribing them. Same is the case with Ciplox TZ, which is a combination of ciprofloxacin with tinidazole. Similar preparation and Norflox metronidazole combination and norfloxacin with tinidazole combination is also there. Similar, ciprofloxacin is actually prescribed against a bacillary dysentery or bacillary diarrhea, and tinidazole or metronidazole is being prescribed for amoebic dysentery. We are actually prescribing in general for diarrhea without making the proper diagnosis whether it is because of a bacilli or bacterial or if it is a amoeba. So we are accounting for antimicrobial resistance, and it should be actually avoided, better be avoided to prescribing this as a FDC in case of diarrhea. And then the next common
excuse me, screen marila
alle.
Okay.
Okay, yeah. Okay. Ipa കാണുന്നില്ലേ?
കാണാം.
Okay. Next is spironolactone. Spironolactone, as we all know, idakka cardiac failure routinely they are seen prescribed. Spironolactone, it is a potassium sparing diuretic when it is combined with ACE inhibitor, that is ramipril. Their mechanism is by inhibiting the ACE enzyme. Similarly, losartan and telmisartan, which is an angiotensin receptor blocker. When they are prescribed together, there is increased tendency for hyperkalemia, and this is a known adverse effect. And it is actually a rational combination, but just we need to monitor for potassium levels at least monthly. And then prescription of doxycycline and ciprofloxacin with calcium salts, that is obviously known to all. Just we need to be more aware of that. Iron salts, calcium salts with antacids, it can form complex and it reduces the absorption. And again, it can reduce the efficacy of these drugs. So next we move on to extravagant prescribing. It is the prescription of more expensive drug when a less expensive with comparable safety and efficacy is already it is existing, but we are issuing a more expensive medicine, mainly because of the claims of the pharmaceutical industries, and that is also accounting for irrational prescribing. So multiple prescribing or polypharmacy, it is more common in elderly, and it is mainly because of the multiple conditions which are present in the elderly. പക്ഷേ പ്രശ്നം എന്താണെന്ന് വെച്ചാൽ multiple prescribing or polypharmacy is directly related to drug interactions and also adverse drug reactions. We have to be carefully, routinely monitoring these patients, and we should check also regarding the patient adherence regarding the multiple drug intake. So as the number of drugs increases, the chance of patient adherence also reduces. So that is why patient education, especially in case of multiple drugs and elderly, is very, very important. Now, what are the impact of irrational use of medicines? Obviously, it results in decreased standard of therapy. It results in ineffective treatment, and then iatrogenic diseases, which can be accounted due to drug interactions, adverse drug reactions, and it increases the chances for antimicrobial resistance, as I've already mentioned, increases the financial burden on the patient, and it also leads on to already wastage of already scarce health resources. It results in drug dependence, especially over prescribing of sleeping pills for the patients, or the patient becomes dependent on those drugs and they start demanding for more drugs. And psychological impact on patients, that's what I already mentioned, that patient demand increases. Patient thinks that for every disease, there is a treatment, and this cycle continues. So how can we promote the rational drug use? So ideally, we should follow an evidence-based clinical guidelines. So standard treatment guidelines is available for India, and for ideally for all states, we should be maintaining a standard clinical guidelines. Our Kerala has got a standard treatment guideline, and ideally we should follow that. അതേപോലെ തന്നെ drug formularies are available. Drug formulary എന്ന് പറഞ്ഞാൽ these are actually books which contains the drugs with indications, contraindications, adverse effects, and every detail like that is there. So we should try to rely on more available drug formularies as well as clinical guidelines. And there should be a common protocol. The Kerala model, it is actually in health sector, it is very good. We should ideally follow the correct protocol. We have got protocol for hypertension, diabetes. Similarly, for all diseases prevalent in our area, ideally for each institution, there should be a single protocol. Then use of national essential medicine lists should be used. This essential medicine list actually includes drugs which are meeting the priority healthcare needs, and these are based on the affordability and efficacy as well as safety of particular drugs. So we should ideally use more essential medicine lists, drugs which are present in essential medicine lists. And then drugs and therapeutic committees should be available in all districts, at least all institutions. I'll be talking about drugs and therapeutic committee in the last slide. Then problem-based training in drug therapy and prescribing in undergraduate curriculum is very, very important to promote rational drug use in future use. And then CME as a requirement of licensure, we need recurrent trainings for promoting the rational drug use, and for each conditions, we need to have a separate CME sessions. Slide മാറുന്നുണ്ടോ? Okay. Okay. Then public education about medicines. What are the adverse effects? What are the problems with multiple drugs? What are the problems related to self-medication? All these things should be made available. Other Ororo institution, area, they can actually create awareness campaigns regarding for the public. And then avoidance of perverse financial incentives. And then sufficient government expenditure to ensure availability of medicines and staff should be made. We are actually working in a situation where we are understaffed and there is high patient load. So accordingly, staff should be posted for better practicing of rational medicine use. So state level, what we can use is clinical guidelines under the state, then essential drug formulary can be followed, and then procurement of medicines which are restricted only to essential medicine list as well as generics should be taken care of. And then training programs for doctors, pharmacists, and nurses can be conducted regarding the rational drug use. And at the district level, we can again conduct the training programs like this. And then prescription auditing on the annual basis can be done. The prescription audit mainly we can include number of prescriptions. So prescriptions on the oral prescription, how many drugs were prescribed and how many antibiotics were prescribed per prescription, and polypharmacy in each prescription, number of drug interactions that can occur in each prescription. All these can be assessed. So a few words about drugs and therapeutic committee. So this should be a committee which is comprising of doctors, pharmacists, nurses, and other medical staff can be included. It is mainly for the hospital drug management. It can be used to elaborate and update on hospital formulary. We can set priorities in drug expenditure. It can be used to make a hospital antibiotic policy. Management of adverse drug reactions can be done, and prescription audits annually or monthly we can actually promote the rational drug use. So ideally, drug and therapeutic committee institutional it can be actually developed and made functional for a better rational drug use. So that's all. Thank you.